on to the next important concept, which is optimal access. So if you scan through the literature, it is reported that 50% of the inadvertent laparoscopic injuries, they occur at the time of entry. When you are going to put your varus needle, there is a reported incidence of 0 to 0.5% for bowel wall injuries, or it could be a major vessel injuries. So safe access is the very important first step of laparoscopic surgery. So from where you are going to access into the abdominal cavity is again dependent upon lots of factors. There are basically two kinds of techniques, closed access techniques or open Hussen's technique. So in closed access, you can start by putting in a varus and then creating a pneumoperitoneum, and then you put your working cannulas or the ports. Or you can go with a direct trocar entry without pneumoperitoneum, which is shown to be slightly more riskier as compared to the varus, because here we are not going to create a pneumoperitoneum. There is a third method of direct entry, but here we are going to use optical trocars like the VZ port and a couple of others which are available. Open access technique, also known as the Hussen techniques, involves a direct incision and placing the port directly without the use of a varus needles. So the operating space in minimal access surgery is actually created by insufflating the cavity or the space with gas. CO2 is our preferred gas. But a laparoscopic surgeon must understand the physiological effects of creating a pneumoperitoneum. You are going to fill that space or abdominal cavity with gas. This is going to increase the intra-abdominal pressures. This will hamper the venous return. This can restrict the movements of the diaphragm. It can lead to hypercarbia, renal ischemia, increased stagnation, pooling of the blood in the peripheries, leading to DVT. So these are all physiological issues related to creation of a pneumoperitoneum. And without pneumoperitoneum, we cannot operate. So a surgeon must understand the recommended pressure and flow settings. These you can find out when you switch on the insufflator and you see the readings on that. So because of lack of time, I cannot go into the details, but briefly touching upon that, in an adult patient, when you're going to operate, the recommended pressure settings for intra-abdominal, intraperitoneal surgeries, the preset pressure should be somewhere between 12 to 15 millimeters of mercury. For extraperitoneal procedures, if you are planning to do a TAP or a TEP or a retroperitoneoscopy, then you need to have a higher preset pressure, and this could be in the range of 20 to 22 millimeters of mercury. The recommended flow rates of CO2 should be 1 to 3 liters only while you are creating the pneumoperitoneum with the use of the varus needle. Once the pneumoperitoneum is created, you are going to take out the varus and introduce your working ports and now connect the CO2 tube to the one of the ports. And while you are operating, you must keep this flow at 8 to 10 liters per minute. Next important principle is tissue handling. Now, I mentioned earlier, there is a lack of tactile feedback in minimal access surgery. Unlike in open surgery, where you can directly hold and feel the tissue, here you are going to operate with the help of these long instruments. And instruments do not have nerve endings. So there is a lack of tactile feedback when you are doing laparoscopic surgery. So more emphasis is paid on visual clues. Look how much you are pressing the tissue. And if you are holding a tissue, how much blanching is happening. If you're trying a intracorporeal knot, in open surgery, you can always pull the two ends and you know that your knots are tight. How do you assess the tightness of the knot in doing intracorporeal suturing? You look at the constriction ring which is formed over the tissue which you are ligating. So these are important visual clues. Movements in laparoscopy are obviously going to be counterintuitive. This is something which you learn with practice and develop the skill of operating with these counterintuitive movements. So a very important aspect of doing surgeries is the use of energy devices. Your electrosurgical units, it could be a standard monopolar, bipolar. Nowadays, we have lots of advanced energy sources like ultrasonic scalpel or vessel sealers. These are very, very integral to doing minimal access surgery. However, please remember, that energy, the electrical current which we are using for dissections is a assistant, it is a add-on, it is an adjunct, and not a substitute for surgical judgment. So be judicious in the use of these energy sources. Again, because of lack of time, I cannot go into the details. But until and unless a surgeon understands the safe use of these energy sources, you can have lots of complications. You can have distant site electrical burns or thermal injuries happening during laparoscopy. So remember to do a safe surgery.